I can see your screen, so whenever you're ready to go.
Great. Welcome again for everybody for joining Journal Club today. For this one, we are focusing on the diagnostic and predictive utility of furosemide, specifically in the patients with renal disease. Wanted to focus a little bit on this part, aside from the therapeutic interventions of furosemide or its association with survivals. And the reason that I picked up this article is that when I first read this article, I was pretty excited about the concept and the findings about being able to use furosemide as a marker that can predict the progression of AKI in the human clinical trials, as well as pulling the trigger for dialysis. And I am still interested in, but after reading these articles and try to compare what we typically approach in veterinary medicine and how this test has been utilized and was proven to be effective tools in the human renal replacement therapy, I came across some questions in terms of how we can apply this from the human studies into our clinic floor and some differences between the literatures. So I'm curious to hear your thoughts on how to tackle some of these questions that we'll discuss today and maybe ask your observations because more or less when we treat these cases, we will likely use furosemide, whether that is for volume management or the referring vet already has administered it before referrals, or maybe in a similar way that what the furosemide stress test is utilized in the human literatures. So just to start off the biomarkers on AKI, there are these various biomarkers in each stage or the aspect of the AKI, from GFR, decreased tubular function, increased tubular injuries, cell cycle arrest, and other response to renal injury. And the furosemide stress test, along with the fractional excretion of sodium and other electrolytes, is located within this dynamic functional assessment of the renal function. And when just as a quick refresher for the mechanism of action for the furosemide, for myself, is that furosemide essentially enters the bloodstream and then it must bind to the albumin to be delivered. And eventually, when it comes to the nephrons, the furosemide is actively secreted into the proximal tubule from the basolateral membrane to the lumen by the organic anion transporters, which we'll come back to this, but this action of organic anion transporters and secretion of furosemide will be inhibited or be competed by the other things such as antibiotics or metabolic acidosis, fluoroquinolones, and other nephrotoxins. And eventually that furosemide that is now in the glomerular filtrate is through the lumen that is carried along to the DACVECC ascending loop, and then binding to sodium potassium 2 chloride channels in the transporters in the apical membrane will result in diuresis. So this mechanism of action is that the furosemide that is not filtered and secreted into proximal tubule and carried all the way along to the DACVECC ascending loop of Henle makes the furosemide as one of the markers that can assess the integrity of the tubule functions. And the other part of this, across all these human trials, even this test has been conducted in a critically sick human patients. It has been reported as giving a single dose of IV furosemide has been safe, feasible, and well tolerated across the studies. So how do they apply this test? First, they're cohort-wise. It is AK stage 1 to 2. And we'll come back to the stagings and the each stagings in a few slides later, but this is very mild AKI stage. And the value of furosemide stress test in these trials is that they are giving a furosemide and see the increase of urine output to see if how of these patients will progress to a stage 3 or termed as a severe AKI or the need for the renal replacement therapy. So the question now is, can the furosemide stress test be combined, or is it have to be combined or compared to other biomarkers like the urine NGAL, is the furosemide stress test providing additional value? So as far as the predictive value that is assessed by the receiving area under the curve, basically just a refresher for anybody that gets refresher. The curve that is assessed here following this cursor, the left top corner, the curve gets closer to the left top corner, the better predictive ability the test have. As you can see in this right bottom figure that is assessing the performance of furosemide stress test comparing to other biomarkers in a pediatric ICU patients, and they compare furosemide stress test compared to urine NGAL and the proencaphalin, where the furosemide stress test predictive ability was superior to the other biomarkers. And the other biomarkers that are compared throughout other trials include NGAL, interleukin-18, blood and urine cystatin C, KIM-1 molecules, etc. And basically, it looks like across the studies, the furosemide stress test itself is as good or superior than the other biomarkers. And there may be some studies suggesting combining these tests with the other biomarkers may improve the diagnostic accuracy only a little bit further. So the way that I see that in this part, the positive about the furosemide stress test, especially in the veterinary clinic floor, it is a easy test, cheap and enough to do in the bedside settings. And how predictive are they, and what are the sensitivities and the specificities? Overall, across these trials in this table, you can see there are so various numbers. In one of these meta-analysis trials that combined 11 human trials, the pool sensitivity and specificity was 81% with 88%. So definitely, as you can see on the right bottom figure, depending on where we put the circles on the ROC curve, we can prioritize sensitivity, specificity, or the vice versa, or balance that both aspects. But it seems to be a furosemide stress test is a sensitive, but also even more specific test. So if the patient responds to furosemide and increased urine output, maybe cannot completely eliminate the possibility that the patients will progress and be need for dialysis. But if they don't respond to it, it is highly specific enough for human medicine to implement strict fluid management and trigger for renal replacement therapy. And not having a ton of furosemide stress tests, but for those patients that are referred over for a dialysis that are already has severely progressed, in short experience, it seems pretty intuitive that those severe patients don't tend to respond to furosemide. So how do they define the responders in the human trials? This review article really had a nice summary of all these different criteria that are together, but it's been done for a long time. But the investigator of this review article actually had published the article in 2013 that published the furosemide stress test in more of a standardized fashion, where they give a single IV bolus of 1 milligram per kilograms. And they define these diuretic naive patients for those patients that have not seen furosemide within 7 days. So if the patient has seen the furosemide within 7 days, then they increase the dose to 1.5. In the future, the later trials, the definition of naive changes a little bit. So some studies still stick to the 7 days, but some other studies define that as within 1 day. And the cohort is very well resuscitated and maybe even concerns for fluid overload, and was or on the IV fluid during this furosemide stress test, meaning one, these patients were not pre-renal component, didn't have pre-renal component. And upon the clinician's discretion of these trials, the patient were replaced the urine output with the intravenous fluid therapy, which I think is another reason why the patient included in these trials turns out pretty, it's been safe and well tolerated across the trials. It's been reported in this study as the specific cutoffs at a specific time points, but it's not only a dichotomous variables that are looking at it, but also the quantification matters. So it's pretty easy and intuitive to think, but giving a furosemide and the less urine output the patients make, the worse progression of AKIs and the outcome of these patients. The cutoff time also varies, but you can see for the most part, these studies are somewhere in between the 2 hours to 6 hours after the injection of furosemide. The first study came out at 2 hours, and many studies still follows the 2 hours, and it seems to be the most predictive in human trials. But in some trials, they actually have presented multiple cutoffs at a various time points. So they say X amount of urine output making in 2 hours from the furosemide injection, but in 3 hours or 6 hours from the injection, Y amount and Z amount of the urine output. But trying to kind of translate these findings into our medicine, because they are reporting as, say, the adult patient, 70 kilograms, made 200 mils of urine over 2 hours. What does it tell in terms of mils per kilo per hour? In average, between 70, 80 kilogram patients that are in these trials, then it comes down to about 1.4, more or less, mils per kilo per hour, is the amount of urine output the patient has produced over the 2 hours. Or these trials also had defined the responder as the urine output that doubles up the amount compared to the before furosemide. And 1.4 is not a huge amount, but and we're going to come back to these stagings in AKN 1 to 2, but these patients are relatively oleuuric. It looks like in the urine output between 0.3 mils per kilo per hour, less or more. So it's a quiet jump compared to probably what their urine output was before furosemide. And in the pediatric literatures, the number varies a little bit more, but still comes down between 1 to 5 mils per kilo per hour. And often it's an absolute value. That's what they've been investigated, than a relative change. So it's not, what they've been focused on is that what is the total amount of urine output this patient has produced at a specific time point. Instead, the patient has produced 0.1 mils per kilo per hour. Maybe they have to change by 3 times or twice. And this article also had a really nice summary of the alteration of pharmacokinetics in a critically sick patients. And in thinking about our patients that come in that are severe AKI or uric, overhydrated, hyperlipidemic, maybe they're on vasopressors. We all know that all of these will alter the biokinetics. But these humans that are tested for this FST were really sick. They were staying in ICU for longer than a week for the most studies, and in hospital for weeks to a month. And they're receiving vasopressors. These patients are septic, associated AKI, patient underwent cardiac surgery, patient that had history or has received kidney transplantation, or the patient is polytraumatized, or patient on the ventilators or vasopressors. So despite all those, the illnesses the patient were included in this cohort, the value of furosemide stress test as a predictive, despite these altered bioactions, seem to be still very predictive and performed well. So we don't have much data in dogs and cats, but it looks like this test holds its value in the AKI ICU renal replacement setting, and it works great in predicting the progression and the need for dialysis in human. Then the next question that I had as I'm reading through this is, should applying this test actually does improve the patient outcome? And here I wanted to briefly introduce a clinical trial at a Cincinnati Children's Hospital. They had a really nice job of implementing this and incorporating this furosemide stress test along with the other biomarkers and the index in assessing their patient ICU, and has came up with nice trials. And also, just a side note, they have a great hands-on course for CRRT as well as Carpe Diem, and they also had a pediatric AKI conference a couple of years ago that I really enjoyed. So in this pediatric ICU, they put together using urine NGAL, renal angina index, fluid overload, and a furosemide stress test to optimize the CRRT use for children. So basically, for any children who is admitted to ICU after 12 hours, or after 12 hours from the admission to ICU, are assessed as this renal angina index. So there's risk strata and injury strata. For any patients that are admitted to ICU, gets 1. Patient may have a transplantation before, has score 3, or the patient came into ICU and on a mechanical ventilation, or the patient came in ICU and on a vasopressors after 12 hours into admission, already at score 6. On the other side of this index, they have this injury strata where it's determined based on the changes in the creatinine and the degree of fluid overload. And then they times the injury and the risk strata to come up with score from 1 to 40. 40 is the worst. For example, the patient came in ICU that is on came in a baseline of creatinine 1.5 that increased to 3.5. 1 times 8 already get a RAI score of 8. And the reason they put it as a first assessment tool is because it's used a similar fashion as a SOFA score in ICU, where it is very highly sensitive enough that they could include any patients who may or may not progress to a severe AKI and need dialysis. So it's been used as a good rule-out screening tool. So the next step they went into is the NGAL, where they divide this patient according to these well-established cutoff numbers, where the patients with the NGAL less than 150, and you can see this the chart here that patient end up going into a standard management as a critically sick patients. But any patient that has a NGAL between 150 and 500, those are the patients that are in the gray area where those patients, according to this flow algorithm, goes to the furosemide stress test. And they established this cutoff point based on the previous trials that shows that the NGAL above 500 are very specific for a severe AKI, where those patients would not necessarily need a furosemide stress test unless the clinician wants to, or they just go straight to the fluid restrict management, start renal replacement therapy at a point where the patient's fluid overloaded at 10 to 15%. And I thought it's pretty interesting they set the cutoff at 10 to 15%. I imagine that overall we probably pull the trigger for the dialysis sooner than getting to 10 to 15%. But seems like that is the cutoff that has been found in the human ICUs, that the tipping point for the worst outcome is that the overload is above that percentage. So patients that has a really elevated NGAL, or the patient that has elevated NGAL but not as severe, end up getting furosemide stress test, and they define the non-responder as urine output does not increase to above 1 mL per kilo per hour in 2 hours. In those cases, those patients get fluid restrict management and renal replacement therapies. So this is the graphical abstract they put out together after they get this nice trial for a couple of years, actually several years. What they have found is applying this algorithm to pull the trigger for dialyzing these patients in a pediatric ICU, the proportion of patients that had a fluid overload was significantly reduced. And then these patients end up receiving dialysis a shorter amount of time, and then staying in ICU for less amount of days, and then improves survival. So this is a relatively small clinical trial in a human scheme of trials, but they had 304 patients, which is a decent size. The other thing that I was a little bit interested in looking into this study further is that what is the particular role of the furosemide stress test within this algorithm? How much was it helpful for making the final call of renal replacement therapy? As you can see here, the 45 patients end up received the test, as well as some of these 97 patients that could have gone into dialysis without the furosemide stress test, and they decided not to report the data. But it seems to be the furosemide stress test was kind of a gatekeeper at the last part of this algorithm, but also reminding about the previous studies that compare biomarkers in the NGAL versus FST. Actually, furosemide stress test was mostly superior to the NGAL for predicting these stages. Then what about our data? Any studies that is relevant to this topic today? not a specific study that investigated the furosemide stress test in the vet medicine, but definitely we have a lot of those papers that describing the use of furosemide. Some of these relevant papers in 2018 JVIM paper talking about the fractional excretion of sodium. They had 32 dogs with AKI that responded to furosemide, but they did not detail what particular criteria that they used to define the responders. And this study also talked about those the patients that receive furosemide and has a positive response that defined as a doubling of their urine output, or the urine output goes above 1. It's not associated with survival to discharge, with less than half of these patients that responded to furosemide. Some other studies in those with lepto-AKI. And there are these other studies that talking about the furosemide, but mostly in the context to convert to polyuria or volume management standpoint. And just wanted to put a blanket reminder that there's this IRIS consensus guideline that tells us that there's no solid evidence that the use of diuretics will change the outcome in AKI in dogs and cats. So we are not, this topic, we are not trying to point here about what are the outcomes that is changed by the furosemide itself, but how we incorporate the furosemide stress test in the human clinical trials that has been implemented and has changed their triggers for renal replacement therapy that might have assisted in improving the outcomes, not by the furosemide itself. So these are the human stages and AKI staging from 1 to 3. Basically, for any patient that has a creatinine over 4, is at a stage 3, or the patient had urine output less than 0.3 mL per kilo per hour over 24 hours. So these trials in the humans are focused on the patient that has really mild AKI, stage 1 to 2, to predict the progression of the stage 3. And one of the landmark trials, the median creatinine of this patient who received this test was 1.23. So that's a bit different than probably the patient population that we see for discussing dialysis. And their goal is to predict or trying to identify those patients that would need a dialysis or progress to stage 3. And the trigger, and this is where I'm curious also to hear from our colleagues and the mentors, is their triggers definitely is not just necessarily depend upon the creatinine, and we talk about we need to assess the fluid overloaded urine output, other index and the biomarkers, but their trigger for the renal replacement therapy is, in terms of the creatinine standpoint, is a little bit a lot less. But in the next few slides, I think I have put together some reasons why I think that changes. So when they talk about this early versus delayed renal replacement therapy in the context of the human AKI trials, they're talking about stage 2 to 3, where 2 could be earlier or 3 could be later or delayed, where we're talking about a creatinine, again, not at a standalone cutoff criteria, but in terms of the biomarkers creatinine-wise, it's about 4-ish. But the cohort of the human trials, they're having these patients that has chronic kidney disease, patients that are hypertensive, heart failure, nephrotoxin exposures like contrast, some other antibiotics, patients that undergo cardiac surgery, sepsis, transplantations, patients that are ventilated, versus not limited to these studies here, but just for highlighting some things from the recent studies. We're talking about patients that had a ischemic injury, severe pancreatitis, or inflammatory disease, good portion of patients that are unknown or infectious glomerulonephropathies. And we actually have a pretty similar criteria in terms of the biomarkers and the urine output assessment. But when these patients come into our clinic that is referred or coming in that in dire or getting close to the dialysis, already patients their recognition of their illness is delayed. My owners notice their dog stopped eating, and it's already a few days after they present with other comorbidities that triggers the AKI, and most of all, the different percent of AKI etiologies that we see compared to these trials. So I think that's one of the limitations that when I was excited about this, but realizing that the stage of AKI and the severity of patients, that we tend to think about the utility of the furosemide in terms of decision-making process for dialysis can be a little bit different. So the next thing that I try to look into is then what if the furosemide stress test could still be has a utility in a patients with a severe AKI. And sorry, I did not put together all these papers out when I signed up for the journal club, and my brain just went to all the different directions. But I just wanted to briefly mention about this study. Pretty interesting. What they have done is in a critically ill human patients, an average about 80-90 kilogram patient. At clinician's discretion, they were chosen to give 20, 40, or 80 milligrams, so up to about 1 milligram per kilogram of single IV bolus furosemide as a furosemide stress test context. In this study, they actually did measure the estimated GFR with the creatinine clearance over 6 hours, the amount of furosemide that are excreted by the urine, so they can, as surrogate marker, how much kidneys will actually be able to excrete the furosemide. And then what they have found is basically in these figures, the blues are the ones that are the worst estimated GFR. And these patients, as you can see from the black to red to blue, the worst GFR estimated and worse furosemide excretion, and the furosemide end up stick to the plasma stream longer. So basically, the worse the kidney function becomes, the lower estimated GFR, less likely to observe the response to furosemide. And just me doing a rough math here, because these blue are maybe the ones that are close enough to our patient course when they come in for severe AKI. If the human's normal GFR is about 90 to 120, and their estimated GFR is less than 20, those are the patients that has a GFR of 15, 22%, or even less. So that kind of makes me curious if we were doing the furosemide stress test in a patient that coming in a creatinine of 10 to 20, maybe it would be challenging for us to expect to see a dramatic difference between the patients who respond or not, given how dampened the patients respond to the furosemide. But if we implement this in a patient, including the hospital-acquired AKI, patients that are post-op, mildly ischemic, we worry about their decreased urine output, they're well hydrated. If they're located in the red to blue area, or in between red and the blue, maybe we could observe the response from the furosemide. I think we do see in patients in clinic, but if we are able to actually do a good research study about looking at this, the estimated GFR and the response to furosemide in clinical patient would be something that I'm interested. So thinking about how to extrapolate, how do I want to extrapolate in the veterinary context? Probably there are many questions that may need to be answered by the research. We talked about this, the earlier AKI stages in the human trials compared to dogs and cats tends to be on the later or progressive stages. So maybe your value of hospital-acquired AKI or the patients that has mild AKI. The questions also, if the performance or the furosemide will be predictive in a severe AKI. And this review article actually did highlight the need for future studies in investigating the stress test in advanced stage 3 AKI in human. And also, if we were considering to do this research or clinically utilizing this information, potentially the higher dose of furosemide in, especially with this advanced stage AKI, which is not completely new, but just this is the nice figure from this paper that actually this blue that has the worst estimated GFR group basically has a really dampened response to furosemide compared to the patient that has the better GFRs. The other part that I think that clinically, when we talk about this the other thing to consider, which is important, is does doing this test necessarily not improving the outcome because it end up might delay initiating the dialysis. And the paper the result is determined mostly in about 2 hours time point, but 2 hours could be a very severe, for severe cases, a long time that could potentially change their outcome. And that trial that I introduced before in a pediatric AKI, not just furosemide test itself, but by incorporating that into their flow charts, they actually observed that the trigger for CRRT was 2 days faster when combined with other biomarkers and the index. But that's on the pediatric ICU setting. So clinical context, if I think about adult coming in with severe AKI with oliguria and likely already has met the human criteria, and everybody knows that the dog would likely needs to go on dialysis route, getting another test to be done before referral, probably not going to help much. Or maybe if that test is done at 4 p.m. and they end up coming the next day, probably it's worse for the patient outcome. Versus the patient that come in as a post-op AKI that is stage 2, relatively oliguria, as ruled out volume responsive AKI, maybe could it help facilitating the decision? I think that is the question to be answered, and a lot other things to be considered other than just the performance of the test itself. So I already kind of talked about this, and definitely also the limitation of the studies that without indwelling UCAT, we can assess the bladder size, but probably not accurate enough to define the cutoffs or finding the more objective assessment to define the responders. As far as when to assess the response, probably it looks like in human and dogs is pretty similar response. And this figure is from the experimental study in healthy beagles, where they gave injections to reduce the renal function. So that's the dotted lines on the below compared to the healthy dogs. And still the diuretic response was observed within 1 hour. So that seems to be the time point, which wouldn't be surprise us, but I just thought it's a nice study that shows still the response occurs in a similar time frame, and eventually combining with other markers that might help to assist our decision-making process. The other part that this review article had talked about is the utility of these tests for predicting renal recovery. So not for initiation of dialysis, but when those patients are about to get off the renal replacement therapy, it did help and also seemed to be as predictive as the initiators. But if the dog or cat has been underwent sessions for 2 weeks and now is about to look at the time, compared to we just look at how much other parameters like BUN, creatinine, and patient's clinical picture, is it worth to doing these tests by placing indwelling UCAT? Probably not seeing a huge value in there, but I'm also curious to hear from the others if there's any other circumstance or some other indications that they see the value of this, not necessarily a stress test, but for any patient context. And this would be the last slide, I believe. Other ways to assess the response to furosemide, not only just urine output. They talk about this urine sodium and fractional excretion of sodium. As the diuresis occurs, the fractional excretion of sodium will be increased. That's more to be determined. They also talk about this furosemide excreted mass, and nice way to dividing. It's more sort of a physiologic test or practice for my brain, but probably a bit far than the case side where we don't routinely measure the furosemide from the urine. So the last consideration, it's again, the context is a bit different. This is more a narrow patient population in human trials and an AKI ICU, also renal replacement therapy. So it's not a generalizable test for all the dialysis cases, including IHD or chronic dialysis. FST has been combined with other criteria for the decision-making process. And also, I think that this is always one of the challenges when I read about these papers talking about this cohort analysis or the group analysis, eventually how that trickles down to individual decision making. It's always the interesting part. With that, this kidney in the slide says thank you, and I would appreciate for any inputs, comments, discussions.
Jiwoong, nice lecture there. I think that a lot of the patients that we see where they're coming from multiple hospitals, days of fluids, we're definitely implementing a lot of furosemide stress tests here just to see what kind of response we'll see. I think a lot of the times, by the time they get to us, they are very much interested in hemodialysis, and so it's a good adjunct to kind of solidify what potential response we'll see, what kind of renal recovery we may see, or really what the potential is for recovery there. So I think it's definitely a nice adjunct to our limited data that we have, especially on the biomarker front.
Thank you. I'm just curious because I feel like for those ones that are pretty much slam dunk for going for dialysis routes, I have to think if any patient had shown a response. I'm just curious about your observation.
Yeah, I think a lot of it is going to be contingent on what type of what is the underlying disease process. I think about the the severe like ICGN patients that actually have good tubular function, and you see a nice response when you're giving them Lasix versus those with a severe let's say ischemic injury that has like a massive tubular injury. You may not see that initial response, but ultimately, over time, and you kind of alluded to, is it worth doing a furosemide stress test in these patients that are ultimately going to get off of dialysis? I think, is that really warranted or not? I think that's kind of up for debate, but I really think that the glomerular disease cases are really interesting, especially when we catch them early, and they come to us with massive fluid overload, and seeing them respond. I think it's a good prognostic indicator for a lot of the owners too.
It's a really good point. Thank you.
I think we have those patients as well that their etiology of AKI might be something that overall has a pretty good prognosis without renal replacement therapy. I'm thinking like an NSAID toxicity or like an ischemic injury. I think if we're getting them when they're really fluid overloaded and they do respond to Lasix, so I mean, we can sort of, knowing that etiology, knowing that they'll probably be okay without dialysis, if we can manage the fluid overload, that's where I think it helps us. I think if it's kind of an unknown AKI or something where, we're expecting a much longer recovery, it probably doesn't change the decision that much, but yeah.
Perfect. Yeah, completely agree. Thank you so much. Okay, there's other points or the comments. Thanks everyone for spending time today, and hope you have a great rest of the day.
Thank you so much.
Thank you, Jiwoong.
Thank you. Bye-bye.